welcome everybody to tonight's discussion. We're going to get things started off talking about a really interesting case, an unresectable stage 3B non-small cell lung cancer. And we're going to be discussing from data from a trial called the LAURA trial. But first, let's hop right into this patient and kind of set the scene for our discussion. So we're dealing with a 64-year-old female, no smoking history. She does have a history of diabetes type 2 and presented really classically with an increasing dry cough over 3 months. So this is how a lot of patients present to a primary care clinic, and they often get treated with antibiotics, which this patient did get twice. And unfortunately, there was no improvement. So this is really a trigger for us to escalate their evaluation. So this patient appropriately got a chest x-ray that unfortunately showed this large left lower lung mass, as well as some concerning mediastinal adenopathy, meaning lymph nodes that were enlarged in the middle of the chest, highly concerning for a lung cancer diagnosis. So we have to move this case forward and really understand what's going on. So this patient, again, had an appropriate CT chest confirming this, what we call spiculated 4 centimeter left lower lung mass, meaning that it has little fingers coming off it. Again, highly concerning for a cancer diagnosis. Again, noting these mediastinal and potentially hilar lymph nodes, meaning to the side of the chest, but these hilar lymph nodes look like they're on the other side of the chest from what the primary lung tumor is. So a further scan with a PET CT scan and an endoscopic bronchial ultrasound biopsy with tissue sampling was advised. So we sent this patient to an interventionalist to get a biopsy of this tissue and really understand what's going on with this tumor. So here we can see the baseline PET scan, and in a PET scan, everything's flipped over backwards. So you can see what looks to be the right side is actually the left lower lung mass, and that brightness on us is showing that that has metabolic activity, meaning it's eating up a lot of energy. So this is an active tumor that unfortunately probably wants to spread and evolve. And you can see here on the other image that we get from this PET scan, on the other side of the chest, that left-sided lesion is actually on the right middle chest there, and that is concerning for lymph node involvement. So now that we have this data, we're able to begin to clinically stage this patient and understand kind of where they are in their disease process. So here we see that she was staged as T3N3, meaning that she had a relatively large primary tumor, as well as unfortunately having her tumor spread from the left side of her body to the right side of her body where we saw those lymph nodes, called an N3 disease. Her biopsy did reveal a non-small cell lung cancer called adenocarcinoma, as well as those lymph nodes also confirming disease involvement. She got genetic testing that we call NGS, or next generation sequencing, that revealed something called an EGFR Exon 19 deletion. This is a genetic mutation that probably caused this lung cancer to happen and grow. So this is where you touch base with a medical oncologist and kind of decide what would your next steps be? What would you advise as your treatment guide? So I'm going to put up a couple of options here, guys. Now that we know that we have this clinically staged T3N3 non-small cell adenocarcinoma with an EGFR mutation, what are our options here? So we can think about inducing patients with systemic therapy or whole body therapy before we treat them with something called Neo-ADORA, giving them a targeted therapy with a medication called Tagrisso or osimertinib to try and shrink that tumor down. We could think about giving them chemotherapy and radiation together and then watch it, which is what our old treatment plan used to be back in the day. We can give them chemoradiation together, followed by an immunotherapy called durvalumab. The same plan followed by a drug called osimertinib for 2 years, 3 years, indefinitely. I think that's really going to be the crux of our conversation here, guys. So now that I've sort of presented this case to you guys, I'm going to start picking your brains. So Dr. Saxena, how would you approach a patient like this? What would you be thinking of your best options right now?
So I think, in this sort of situation, with the stage 3 disease, one thing that we typically do, although this case is a little bit more clear cut, is we do have them evaluated by the surgeon to make sure that they're not a patient that could undergo surgery. Typically, we don't end up doing that in patients like you mentioned in this case where the cancer has gone to the other side of the chest where the lymph node is, but in maybe someone that was a little bit less advanced where all the lymph nodes were still on the same side as the primary tumor, and in sort of that center area of the chest, we would have them see a surgeon to see if some induction followed by surgery would be an option. But in this case, I think I probably wouldn't think that that would be appropriate. So in those cases, concurrent chemo and radiation, which is in, basically choices 2 to 6, would be where I would go. And the question about what to do after that is sort of the difference between those. And I think based on the data, which I know we'll kind of go over right now, it would suggest that the answer would be the number 6, concurrent chemoradiation, followed by the osimertinib indefinitely. The other sort of treatment, the osimertinib is a tyrosine kinase inhibitor. It's specific for patients with EGFR mutations. And the reason, we would probably favor that versus the number 3, the durvalumab, is that those patients, durvalumab is an immunotherapy drug. So, immunotherapy obviously is used a lot in non-small cell lung cancer, but in these patients that have EGFR mutations, it doesn't seem to work well. And if you look at the studies looking at durvalumab after chemoradiation, if you look specifically at the few of the patients that had EGFR mutations, they really didn't benefit from the durvalumab. So I think, that sort of narrows things down to choosing choices 4 to 6. And then how long to do the osimertinib, which is kind of the difference here, is I think, not really clear. The study I know that we'll go over did it indefinitely, but do you actually need it indefinitely? I don't know that we know that for sure. The sort of way that this was sort of presented was that these patients are very advanced and they're probably going to need treatment all the time to keep the cancer from coming away. But, you do cure some of these patients with just chemo and radiation. So it's hard to say that everybody should get it all the time.
Wow, great answer. You unpacked a lot of really important concepts for us there. And I agree with your first point here is, it is always important to have an interdisciplinary discussion about these cases. You always want to have a surgeon involved, a radiation doctor involved, your pulmonologist, your radiologists, all those team members and pathologists as well to help make this decision together. But unfortunately, because this has crossed over the midline, remembering that the left side went to the right side, as you said, this is very unlikely a surgical candidate. And you really hit on an important point about considering immunotherapy and targeted diseases. So before we talk about this any further, let's dive a little bit into the data and really get to some of those questions that you alluded to. So we're going to be talking briefly about the LAURA trial. So the LAURA trial is a phase 3 double-blind placebo-controlled trial, meaning this was a large study with a lot of patients. We did not know who was getting the study drug, who was not getting the study drug. And this was specifically for patients with an EGFR or epidermal growth factor receptor mutated stage 3 non-small cell lung cancer who did not progress during or after chemoradiotherapy. So these are patients who went through chemotherapy and radiation together or sequentially with chemotherapy to radiation for stage 3 disease. And then they, in a 2-to-1 fashion, so 2 patients for every 3 got assigned to the osimertinib or Tagrisso arm, with 1 patient getting a placebo. And they were looking at something called progression-free survival, how long before this tumor starts progressing again, if it ever does. And you can see here some of the data, really striking data here. For those of you who don't look at these types of curves all day like us, what we see here is in the yellowish color, this is the amount of patients who are progressing on the osimertinib or Tagrisso arm, the ones who got the study drug after radiation versus those who got placebo. And you can see here that the yellow is much, much higher than the blue, meaning that many fewer patients were progressing when they were taking the study drug versus those who were taking the placebo. And a difference numerically of 39.1 versus 5.6. Those are really large differences as far as months, and something called a hazard ratio of 0.16, which is a really impressive number for what we see in these clinical trials. But of course, one of the most important endpoints we are always thinking about is, does this make patients live both longer and better? And I think that that's one of the things we're still trying to understand about this trial is the overall survival, is what we call it. How long are you going to live if you try this new study treatment? Is still maturing. It is leaning towards patients surviving longer. But then the question is, what do we want to do as far as side effects? Is the juice worth the squeeze, as they say? Are the side effects from this therapy worth it? So, you know what? I decided that I'm going to put this patient on osimertinib. We have a discussion about 2 years versus 3 years versus indefinitely. But I think for the appropriate patient, particularly this one who had an unfortunately relatively advanced disease with real recurrence rates that are unfortunately disappointing for us right now as we're increasing our benefits across the board for lung cancer patients, this is an area where we still need to do better. So, what we saw is that I put this patient on. I decided to go for 3 years, really trying and get them towards a meaningful endpoint of 3 years after their definitive therapy. But some reason they went to go see Dr. Saxena for a second opinion, and this guy's thinking about what to do next. He checks a blood test, and it shows that there's actually no EGFR mutation in the blood that we can find. So, Dr. Singhi, what am I supposed to do with this case? This guy, Dr. Saxena, is telling me, oh, I don't see any blood, ctDNA. There's nothing that's showing me there's an active cancer here. Is this the time that you're going to want to stop therapy? Are you going to continue therapy? Or do you think maybe we should have stopped sooner than this?
Yeah, I think you're asking all the right questions, Dr. Rose. It's really tough. We want to offer an opportunity for our patients to de-escalate therapy, right? To continue to live their lives with a good quality of life, minimize potential side effects, get back to normalcy, whatever that means for them, right? But I think what you pointed out in the OS curves that we saw earlier, the PFS curves rather, chemo RT alone still has a high rate of the cancer coming back, and what we saw is that the, introduction of osimertinib after chemo RT really decreases that risk, not only just kind of within the chest, but also in the brain. It's protecting the brain too. So I have a lot of reservations about fully dropping osimertinib for these patients. We still don't really know the role of ctDNA dynamics, whether it's being cleared, whether it's still present or positive. How is that supposed to tailor our treatment recommendations? Not yet ready for clinic, in my opinion, especially when there's a sort of high risk, high reward situation here. So I would say shared decision making is really important, making sure patients are being optimized with their tolerance of osimertinib, thinking about their quality of life, and then having that nuanced decision kind of one-on-one with the patient.
I think you really hit the nail on the head in my mind as far as this being a shared decision with the patient, because there are a lot of pieces here that are not unknown or pieces that are just really patient centric as far as what are their goals, where are they in their life, what other medical issues do they have, and what are their thoughts on taking an oral therapy potentially indefinitely when they may not even have cancer anymore. So I think there's a lot of questions in that space. So Dr. Prishagul, this is where we're really having these deep patient-centric discussions. You know, you might recur, but you're having low-level skin rashes and diarrhea or paronychia, which are little annoying, painful things in your nail beds, or you're just kind of tired all the time. If I'm offering this to a patient for a brief period of time, 6 months, a year, maybe I'll feel a little bit less bad about exposing those toxicities. But if we're talking about indefinitely, having those low-level side effects can actually really build up over time and be very exhausting for our patients. So how do you see the balance between that, what we were talking about before? Are we over-treating, under-treating? What are your thoughts?
So yeah, this is definitely an area that I have, really invested a lot of time and thought in regards to toxicity. I think everyone, when we're evaluating trial data, we get all uppity, about grade 3 and God forbid grade 4 toxicity. But what about those patients that are doing great on study and have the grade 1 toxicity or grade 2 that I think there's even movements right now to think about, like, not even reporting those, but those are a big deal, right? Like, you're going to be on this treatment for the rest of your life and you have grade 1 paronychia and you can't get your, every 2-week gel manicure that really makes you happy, that adds to your quality of life. Like, we might smile, we might laugh about it, but like, that might mean a lot to Mrs. Smith. And that makes her happy. And she has to be on this drug for the rest of her life. And now her nails are brittle and she can't do that. She does that with her granddaughter. That makes her happy. Like, then that makes me not happy. So that's not cool. And that's something that we have to think about. You think about the rash, you think about photosensitivity, right? What about someone that lives in Florida? We're easy. We're up in the Northeast, Dr. Rose and Dr. Saxena, we're right in New York City. We don't have summer all year round. We only have to worry about a lot of like sunscreen and stuff for a certain amount of time, but like you're down in Houston, you have sun, a lot more than we do, Dr. Singhi. So like you have to think about these patients need to avoid sun, sunscreen, cover up. It's hot as you know what down by where you are all the time. Like that's quality of life too. So I don't feel comfortable committing my patients to indefinite OC at this time without no end, right? So if I were to pitch this to a patient or discuss this with a patient, I would probably say the data shows that osimertinib should be continued indefinitely, but that is not true for everybody. And I would say some is better than none. But how much of that some, I don't think we know. So I think we would have to take it on a case-by-case basis with the understanding that if you ever wanted to dose reduce, there's room for that, right? Osimertinib is given at 80 milligrams, but we can drop it to 40. It still has efficacy. I think it's worth a shot. It's unclear what the efficacy is in regards to CNS penetration or penetrating into the blood-brain barrier to prevent brain metastases, which is what we're really worried about in these patients. But I think it's better than none. But if someone wanted to come off treatment, which, if it's not vibing with them, if their quality of life is in the gutter, if they're really not feeling well, they can't tolerate it, or they're like, listen, I'm just done. Then I would make sure that I got a PET. I would make sure that I got an MRI brain. I would make sure that there really is absolutely no disease head to toe. And then I would survey them very aggressively. And that would also include surveying the brain, because we know how patients that harbor EGFR alterations that are driving their lung cancer, how hungry their disease is to metastasize to the brain. So making sure that we're really aggressive about surveying this, I think is very appropriate. I can't say I would do it as often as they did on the study, because that is also hindering a little bit on quality of life as well, making them come more frequently than maybe standard of care. But I would definitely be very aggressive in surveying it and have a low threshold to get scanned sooner rather than later. In regards to cost, I think that's something that we also, we deal with all the time, right? You send someone a prescription for osimertinib and it's $10,000 for a month, and you try to, submit them to the, patient financial team or the other, there's grant opportunities, there's philanthropic funds, there's other, financial support programs that we have, but sometimes that doesn't work. Or I know Dr. Saxena, you worked very hard with some of us on this call to help offset some of that, but they changed the financial criteria for patient financial assistance. So, it's something that we need to think about. $2,000 every month or even $50 every month for the rest of your life is a lot of money. So I think that I don't make this decision lightly. As everyone had said on this call, it's really patient-centric. And I don't think we have enough information to know if indefinite is the right answer.
Wow, you guys have really hit on, I think, all the highlights of this situation. I think for better or worse, we have a really complicated job these days integrating all these data points, all the new therapies, and how they're applying to different situations for each of our patients. So I love that we're talking about all those things. I smiled when you said getting your gel done, because my patient just a couple weeks ago had that exact concern. She loves getting her nails done, and this was really upsetting to her. So I think that those are really important points. The cost of this, we know that healthcare is unfortunately the number one cause of bankruptcy in America. So we really have to be thinking about people's pocketbooks and making sure that we're keeping them financially healthy as well as physically, mentally healthy, making sure we're not wearing them down with long-term, low-grade side effects. So just so many different things to unpack in this trial. And that's why we're having these types of discussions, to really highlight all these important points along the patient care journey, because it really is a case-by-case situation, patient-by-patient situation, how we're making these decisions.